What's going on, everyone? Welcome back. Today is our last lecture in the upper extremity series. We're going to look at the wrist and hand, and then next week I'll be out of town, so we'll have a week off, and then the following week we'll jump into lower extremity and start on the hip. So anyway, I hope you are enjoying these. Feel free, as always, to put any questions down in the comments section, and all right, let's jump into it. So wrist and hand, start off here looking at a bit of structure. So just generally from a functional standpoint, we think of the wrist and hand as being important, obviously, in controlling all the joints of the hand, which we'll look at, this multi-articular structure, just all of these joints in the hand. All of the coordinating the muscles that control all of these joints. We'll look at muscles that both run through the forearm. So a lot of our big torque force generating muscles for the wrist run through the anterior and posterior compartments of the forearm. And then down within the hand, we have a number of other smaller muscles that are involved in not so much the larger force production type movements, even though they do contribute to that, but also just all of the fine motor control aspects we have of our hand. So, just generally from a functional standpoint, the hand is obviously really important for conforming to different types of objects. So again, we can feed ourselves, drink, carry out things in our environment that are necessary for our survival. Fine adjustment of grip. Later in the lecture, we will look at different categories of grip: power grip and precision grip. I've done some posts on my account in the past on social media on power grip and different ways to train those grips, but we'll look at those two categories, and then I'll give some examples in between of precision and power grip. The wrist and hand is often referred to as the most complex joint of the human body. It's actually a really interesting area from a rehab standpoint because physical therapists and occupational therapists, there are some out there who specialize in treating the wrist and hand only, and they have the letters CHT after their names, which stands for Certified Hand Therapist. You have to spend 5,000 hours treating the hand before you can even take the exam to get certified. So it's a unique, because it's such a complex area, rehab practitioners will really specialize and only treat the wrist and hand in those cases. So a very complex area of the body. And when we think about the wrist, or the other name for the wrist is the carpus, we're going to talk about the radial carpal joint. So we're going to look at where our radius, the long bone on the thumb side of your hand, where that comes down and meets the carpal bones in the wrist here. And we'll look at the two rows of carpal bones. So there's that joint, which is the main, probably what most of us would think about when we think about the wrist. So that's your radial carpal joint. And then there's two rows of carpal bones, these small bones right here in the hand. And in between those two rows of bones is the midcarpal joint. So really those two joints, the midcarpal and the radial carpal, are going to work together to give us all of our wrist movements. Okay, so just a bit of introductory material. This is a really cool video from Chicago Sports Doc. I put a lot of his videos on my account, but he's based in Chicago, and you can look him up on Instagram. But just great dissection videos. So just a great one here of seeing the wrist moving through ulnar and radial deviation and then up into extension. So we've got the top side of the wrist here, right? And then the wrist is moving extension. You can see the tendons here as they come down and hook into the various aspects of the hand and fingers. So, there's nothing like cadaver dissection for learning anatomy. So if you ever have a chance to sign up for a class in dissection, definitely encourage you to take it. Okay, so a bit more here on structure. When we think about movement available at the wrist, it's said to have 2 degrees of freedom. So we have both sagittal plane and frontal plane movement. So when you think about the wrist in anatomical position, standing with our elbows straight and our hands supinated, the wrist moves in the sagittal plane in both flexion and extension. And then in the frontal plane in radial and ulnar deviation, if you can see that. So right towards our thumb is radial deviation, and then the other direction towards the pinky is ulnar deviation. So we really got those 4 movements, 2 planes of motion, 2 degrees of freedom in terms of the wrist. The radiocarpal joint, from an anatomical perspective, again, proximally is made up of the radius and the radial ulnar disc. And then that bone, so your radius is the main forearm bone that contributes to the wrist, and then it is going to, on the other side of the joint, we're going to have the carpal bones of the first row of carpal bones. So we've got the scaphoid, lunate, and triquetrum. 3 bones. There's another bone you might remember called pisiform that's in that proximal row, but it doesn't contribute to the joint. It has a different purpose, and we'll talk about it later. And then the other element to remember is the TFCC, which is the triangular fibrocartilaginous complex, which is a piece of fibrocartilage that is also in the wrist joint. It helps to cushion compressive loads. Sometimes you hear of people tearing the TFCC in various sports, and that can cause wrist pain. So you might hear of that at points, but that piece of fibrocartilage helps to kind of cushion against compressive loads in the wrist. So again, that's the radiocarpal joint, which is one of the joints of the wrist. And then we have the midcarpal joint, which is basically a joint between the 2 rows of carpal bones. So the first row of carpal bones we talked about up here in the radiocarpal joint, scaphoid, lunate, triquetrum. So those 3 bones are now here, right, are the proximal. This is the proximal component of this joint. It was the distal component of the radiocarpal joint. So that first row of carpal bones is right here, and then the second row of carpal bones are trapezium, trapezoid, capitate, and hamate. So in between these 2 rows of bones is this midcarpal joint. So really those 2 areas, the radiocarpal joint and the midcarpal joint, these 2 are going to work together to allow us to have our flexion, extension, radial and ulnar deviation. So I know that's a lot on one slide, but hopefully it all makes sense. Okay, just an image here just to kind of get your mind thinking about the bony anatomy of the wrist. So we can see the radius coming down. The radius, again, is going to be the main forearm bone that articulates with the wrist. So right in here, so there are 3, here are our carpal bones. This first 3, the proximal row, are going to articulate with the radius to make that radiocarpal joint. And then in between here is where the proximal carpal row and the distal carpal row will make up the midcarpal joint. And then once we get past that, we'll start getting into the metacarpals and then the knuckles of the fingers. Okay, so for right now, just focus on these 2, radiocarpal and midcarpal. Over here, we have an image here of an injury to the TFCC, just to be able to see that piece of cartilage in a bit more detail. And again, you can see the radiocarpal joint right here, and then the midcarpal joint would be in here, in between all the small carpal bones. Okay. Other structures are, we will have the intercarpal joint. So besides the 2 rows of carpal bones articulating with each other, in between each of the bones, so here, for instance, we would have intercarpal joints in between. So from one carpal bone to the next, there would be an intercarpal joint here. So again, this is why the wrist and hand is so complex. You've got all these bones, all these joints, the ligaments and muscles that are controlling all of it. So it's really a complex area. So again, these are intercarpal joints, are the articulations between carpal bones. When we break down the 2 rows, we'll break them down in terms of their mobility. So that proximal row, again, you'll remember, is the scaphoid is near the thumb side, lunate, triquetrum, and then out here is this little bone pisiform, which has a different function, but this row in general is more mobile. This proximal row has more mobility to it. It's more flexible. Pisiform is a sesamoid bone. So you may have heard of sesamoid bones. They really are there to help enhance the power of certain muscles. So for example, the kneecap is a sesamoid bone. The patella is a sesamoid bone that enhances the force, the torque capabilities of the quadricep muscles. Pisiform has a similar function, and it helps with flexor carpi ulnaris, which is this muscle that runs through the anterior compartment and helps with flexion and ulnar deviation. Part of the reason our flexors are stronger than our extensors is because pisiform helps to enhance power of this muscle. Okay, that's the proximal row. So the proximal row is a bit more mobile. And then we have the distal row, which is relatively immobile, and again has these four bones we mentioned before: trapezoid, trapezium, capitate, and hamate. So just breaking them down into kind of mobility and also introducing pisiform and its function. Okay, just another image. I just like this one. It's just another good one to really help you sort of think about the bony anatomy. Again, a good one for seeing the radius and how large it is distally and how it forms this radiocarpal joint. So we have these proximal three carpal bones really forming that radiocarpal joint, midcarpal joints in between the two carpal rows, and then all these little intercarpal joints. And then we'll start talking about, trapezium is an interesting one we'll talk about later with osteoarthritis of the thumb. Many people get osteoarthritis right here in this joint. It's called the carpometacarpal joint, so it's where trapezium forms a joint with this first metacarpal. So that, you can see osteoarthritis there, but we'll talk about the other. These are called the carpometacarpal joints. And then we have these joints up here, which are really like your knuckles, the main knuckles if you punch someone. Those are the metacarpal phalangeal joints, MCPs, and then we get into the phalanges, the fingers, and the phalanges have these small interphalangeal joints, the distal and proximal interphalangeal joints. So if you haven't studied the hand before, this probably can be a bit intimidating, so don't worry, just go through it a number of times, and it's just some memorization like everything in anatomy, so just spend some time and you'll get it figured out. Okay, ligaments, there's a ton. I'm not going to name all the ligaments in the hand, there's just tons and tons of them, but just some general functions. They're responsible, like ligaments and other places in the body, for providing stability to the joint and guiding and checking motion. That's what ligaments are really about, is restraining movement. And by restraining movement, they protect the joint and surrounding joint structures. There's two categories in the wrist. We'll talk about extrinsic ligaments that connect the radius and ulna, the forearm bones, to the metacarpals, those kind of long bones in your palm. And then intrinsic ligaments, which connect carpal to carpal. And there's just a whole array of ligaments. I've got an image here. I link this one. This one always cracks me up because it says here, the wrist is a sea of ligaments. So it just, it's an illustration, but just gives you an idea of how many different ligaments, if we were to go through and name all of them, that connect all these bones together and really contribute a huge degree of the control. That foundation of ligaments that restrain and guide motion are a huge part in how much control we have to our hands. They sort of form the foundation, like the structure, the foundation to a house in a way. It gives it it holds the bones together, and then the muscles can work within that. So, okay, arches of the hand. We've got the proximal transverse arch, and this is also referred to as the carpal arch. This is sort of like when we think about arches in the foot. So we've got arches in our hand. If you look at your hands when they're at rest, they form this sort of arch, almost like your foot does, just kind of this relaxed position. We'll see these arches. So the carpal arch runs across the distal carpal row, right? These were the bones from the distal carpal row, trapezoid, trapezium, capitate, and hamate. So this carpal arch runs across these bones, and it's a relatively fixed, stiffer kind of arch. So that's the proximal transverse arch. It's closer to the shoulder, farther up the arm. And then we have a distal transverse arch, which runs across the metacarpals. Okay, so these arches are primarily ligamentous. It's a dense connective tissue. This metacarpal arch is more mobile, helps us, again, sort of change the hand, change the shape of the hand, so we can conform to different objects. And then, we've got these two horizontal arches, and then we've got a longitudinal arch that connects to the two, and again, contributes to this resting kind of arch we have in our hand. Okay, so 3 arches to keep in mind. And okay, so let's look at kinematics. So let's look at some of these big movements. Again, we've only got 4 movements to cover. So we've got flexion, extension, and remember anatomical position. If we were standing in anatomical position, our palm is facing forward. So flexion is the fingers coming sort of forward away from the body, and then extension would be the fingers pointing back at you if you're in anatomical position. Okay, so the joint axis for this, if we're moving in the sagittal plane with flexion and extension, the joint axis is running from medial to lateral through the side of the wrist, which allows us to pivot this way. And in terms of range of motion measurements, we're going to have a bit more flexion. So if you look at flexion, you put a little pressure on it. See, mine almost gets to 90 there. I've got pretty mobile wrists, but textbooks will say about 75 to 85 degrees. And then extension is going to be usually a little tighter for people, somewhere in the neighborhood of 60 to 85. It could have the same upward maximum depending on how flexible your joint is, but most people will feel a little more resistance with flexion they'll feel a little more resistance with extension, and flexion will feel a bit easier. Sorry if I mixed that up. So flexion tends to be easier. Range of motion, on average, people have more range of motion this direction. Extension, a little bit tighter. People will feel some of the resistance through these flexor tendons, so that will limit extension a little bit. This is how we get stretches in our forearms and things like that. Okay, those are our sagittal plane movements. And then we have our frontal plane movements, which are going to have an anterior to posterior axis running from anterior to posterior, which allows us to create these kind of movements. And again, in terms of range of motion, we have less radial deviation. So radial deviation is when you move towards your thumb, or a lot of people will teach it as rad dude. If you think about rad, that's your thumb side. So radial deviation, that's going to be around 15 to 21 degrees. It's blocked by the radial styloid, which is a bony eminence that comes off the radius that blocks movement. Ulnar deviation, we don't have that same kind of block, so we get quite a bit more, and this will be listed as 38 to 45 degrees. So if you were going to use a goniometer and measure someone, those would be kind of the normals you would be thinking about and when trying to decide if someone has a limited mobility. Okay, so those are our osteokinematic movements: flexion, extension, radial and ulnar deviation. Radial and ulnar deviation can also be called lateral medial deviation, but most people will say radial and ulnar. Okay, a little bit about the thumb. So I mentioned this joint before. This is where we see osteoarthritis. We'll talk about it more later, but this is the carpometacarpal joint. So it's where trapezium, this carpal bone, hooks into the metacarpal here of the thumb. Okay, and that joint is unique. It's a saddle joint, which is if you remember from one of the very early lectures, we talked about different types of joints. The saddle joint, this is one of the few places we see it here in the thumb, and it allows us to have this huge range of movement at the thumb, which, as you know, the thumb is huge. Our thumb is part of what makes us unique as primates, being able to use that thumb to touch the other fingers. It allows us to grab things. It's a movement. The movement of touching the other fingers is called opposition, and it makes us unique in terms of our hand structure. And so here the most important motion of the thumb is opposition, which literally just means touching the pad of your thumb to the pad of your other fingers. So the fact that we can do that, again, just adds a huge degree of functionality to our hands and sets primates apart from some of the other mammals. All right. Muscular activity, just again, sort of general categories. One muscle we'll talk about more specifically is flexor carpi ulnaris. Because it is the most powerful motor of the wrist and hand, it's the one that runs over pisiform, so it runs down the ulnar side of the forearm on the anterior compartment because it's a flexor. So it mainly creates flexion and ulnar deviation, and it's very strong. You can almost just put your hand in that position and feel that it's strong there. But a ton of muscles in the forearm that if you take anatomy, you'll go through all of them. The flexors are greater than twice as strong as the extensors. So, and again, I think most people would intuitively kind of feel that. You can squeeze a lot stronger with your flexor muscles than you can with the extensors on the back side of the forearm. Here's a great video from Seattle Science Foundation. It's narrated, so I'll let him talk through, but just a neat way. He's not going to mention all the muscles in the anterior compartment, but we'll get a chance to see some of these flexors, and he'll kind of pull on them so you can see the fingers move. So
if we come to the flexor digitorum superficialis, we'll pull on the tendons that go to the ulnar digits. We see flexion of the intermetacarpal joints. Move around the corner to the superficialis that goes to the second and third digits. We see those with some flexion. We'll go deeply. This is the flexor pollicis longus, so we'll pull on that and see flexion of the thumb. We can find our flexor carpi ulnaris, and with some tension, we'll see ulnar deviation of the wrist.
all right, so sorry if that kind of those dissections bother you, but just a great way again to see the anatomy. So when we look at muscular activity of the hand, like the ligaments, we're going to talk about two categories. So extrinsic muscles, in terms of function, are going to be responsible for placing and changing the shape of the working hand. So placing it where we need it to be, changing the shape of the hand to be able to grab different objects. And then the intrinsics, along with the ligaments, are going to be responsible for maintaining the configuration of the three arches. So the two transverse arches and the longitudinal arch, keeping the shape of the hand. Sort of almost like deep stability of the hand. A lot of times that's what we see with intrinsic muscles, that they have a primary stability role. Extrinsics move the limb and generate force. So that type of concept fits in the hand as well. Okay, now we'll talk about grip here a bit. So prehension is another term for grip. As I mentioned before, there's going to be two categories. We'll have power grip and precision grip. Within power grip, there's going to be different types, but when we look at it, all of the finger joints, so the metacarpal phalangeal and the proximal and distal interphalangeal joints, are in a flex position. And the wrist is often slightly extended to help tension those ligaments, because that allows us to increase our grip strength. So if you imagine, if your flexor muscles here, your wrist and finger flexors, are running in this anterior compartment, when I'm squeezing my fingers, if I want to make a strong grip, it actually helps to extend the wrist slightly, because it puts more tension on these muscles and tendons, which pulls the fingers closed and helps with grip strength. You can notice this if you put your wrist into flexion and try to make a fist, it's much weaker than if your wrist is in extension and you make a fist. So, and that has to do with slack and tension on these flexor muscles and tendons. The three grips are cylindrical, spherical, and a hook grip. Cylindrical would be like if you were grabbing a glass maybe of water, something like that, something that's more of a cylinder type of shape. Spherical is like a ball. And then hook grip is one that's sort of a hook like this, almost like if you were carrying a bag of groceries, or if you think about weight plates in the gym. If you think about the big plates, some of them have a lip that you can kind of hook your finger on and carry them. That would be more of a hook grip. And I have a post on this if you ever want to look back and at those three grips and how you could train them. Okay, and then we have precision grips. So these are going to be more of a fine motor type of task. They involve using the thumb and the fingers, that opposition kind of movement. So one is pad to pad. So if I take the pad of my thumb and touch the pad of another finger, that's a pad to pad precision grip. And then we have tip to tip. You know, the tip of the thumb and the tip of another finger. Maybe you're picking up something really fine and small from a table or the ground. And then the last is pad to side. If I take the pad of my thumb and touch the side of my index finger, a lot of times we hold keys like that. If you were going to unlock your door, you might hold a key with a pad to side, or maybe even depends on the person, but some people might do pad to side with a pencil or a pen. Some people do pad to pad. So we have different strategies, but those are the three, generally the three precision grips. Okay, I always like to end with a few pathologies, hopefully to make all this relevant for you as you're working with clients and patients. So what do we have here? We've got carpal tunnel syndrome, a huge one in the wrist. Involves the median nerve. This is more common in women than men. You don't see it a lot in young people, although you can if they have really jobs or complete tasks that are really repetitive with the fingers and hands. The exact cause of this is unknown, but we do know that it involves the median nerve. So usually it's a compromise of this median nerve, and usually the microcirculation. So your nerves all have their own microcirculation. If that is compromised in some way, then blood flow, oxygen delivery, nutrient delivery, those things are reduced to the median nerve. And this can happen in other spots in the median nerve. If we think back, median nerve, its nerve roots start in the neck, C5 through T1. It runs down the arm. So there are various spots where it could be compromised, but the carpal tunnel is said to be the most common. And again, there are posts, and I have posts on this. There are studies out there on ways to actually kind of mobilize the carpal tunnel. There's been a new actually technique where the person's arm is like this, and they move their fingers from adduction to abduction, and that's been found to create maximal excursion of the median nerve in the carpal tunnel. And those mobilizations can help with fluid dispersion to the nerve, which means more nutrients, more oxygen, just more blood flow overall. And a lot of people with nerve deficiencies, nerve-type syndromes, those kind of mobilizations can be helpful. Here's an image. I just like to show it because it shows the median nerve here. There's all these other tendons. The carpal tunnel is really a pretty amazing space. If you look at it from a cross-section, you've got 9 structures in the carpal tunnel, 8 tendons, and then the nerve, all in this little space. So sometimes you hear people having a carpal tunnel release. If their symptoms don't get better, sometimes surgeons will cut this transverse carpal ligament which will help relieve pressure on the median nerve. But obviously prior to that, we'd like to do exercises and movements to try to improve blood flow to the nerve and get it healthier in that way. Your median nerve innervates your thumb, index finger, middle finger, and a portion of your ring finger. So people with carpal tunnel syndrome will often talk about numbness and tingling in this aspect of their hand, the lateral part of their hand. Okay, so obviously a really common one in the wrist and hand. Probably everybody's heard of carpal tunnel syndrome. Other ones, sprains are really huge in the wrist and hand because of how many people fall. They fall to the ground, skiing, snowboarding, skateboarding, just you slip on ice in the winter, and people will fall and put their hand out and sprain their wrist. Again, this is usually due to a fall on an outstretched hand. It can lead to chronic wrist pain like other sprains if left untreated. Most people heal, but sometimes we can see chronic issues. The lunate capitate and radiocarpal ligaments are most commonly involved. So we've got an intercarpal ligament here between 2 carpal bones, and then the larger kind of just general wrist ligaments. Obviously, if you fall with your wrist extended and land like that, you can injure. These are the most commonly injured ligaments, but lots of ligaments you could potentially sprain and stretch. Again, any ligament could be injured. So like a sprain anywhere else, kind of you think about like an ankle sprain and injuring those ligaments with a twisted ankle. This is sort of a similar thing. People usually fall, and most of us when we fall, we stick our arm out. Just that's our natural protective mechanism, but it often injures the wrist. Colles fracture is a fracture that's also very common with a fall on an outstretched hand, but it refers to a fracture of the distal radius. I was talking about that radial styloid earlier that blocks radial deviation. So that little bony spot that sticks out, if you land in a fall, it can break that piece off, and that's called a Colles fracture. Extra-articular just means it's outside the joint capsule, which is actually good. Intra-articular fractures often cause lots of problems because they affect the joint. But because this is outside the joint, it's a little easier in some ways to recover from. You can also fracture the ulna with that type of injury, but again, one of the most common fractures, and usually also from a fall on an outstretched hand, and sometimes we call that a fouche injury. So I don't have that on here, but also this fracture is associated with that type of, and then also, really a fracture we would worry about in people with decreased bone density. So if somebody has osteoporosis or osteopenia, not only is this fracture common anyways, but then if your bone density is compromised, it's even more common. So Colles fracture. And here, just an x-ray showing a fracture, again, of the distal radius. So most likely somebody fell on their outstretched hand. So you've got the normal looking radius here, and then a fracture through the radius. So De Quervain's tenosynovitis. I always like this name. It's a good one to call in sick to work with because nobody will know what you're talking about. But De Quervain's tenosynovitis is an irritate. It's so again, this one's fairly common. Inflammation and swelling of the sheath. So tenosynovitis is different than tendinitis or tendinopathy, which affects the tendon itself. This affects the sheath, and not all sheaths have tendons. So only tendons with a sheath can develop tenosynovitis. But this one, our abductor pollicis longus and extensor pollicis brevis, these two have sheaths around them, and the sheath can become irritated, and people can develop this de Quervain's tenosynovitis. Usually what happens is people will have pain on this side of the wrist near this little indentation. It's called the snuff box. So people will have pain over here, and that will limit thumb range of motion, especially when their thumb goes in. When they adduct or flex their thumb, it will put stretch on those irritated tendons in that sheath, and that will cause pain. Often ulnar deviation hurts with this as well. And the test that's done for this is one, if you're wondering or suspecting that maybe somebody has this, what you do is you have them put their thumb inside their hand like this. They straighten their arm, and then they go into ulnar deviation. If that hurts right here, then that can be a positive test for de Quervain's tenosynovitis. So just do it really slowly with people, because if you do this quickly, it can really be a sharp pain right there. So you just if they put their thumb in and just gradually go into ulnar deviation, that's the test for, wondering if this is what might be causing their pain. Okay, scaphoid fracture and a lunate dislocation. So another injury related to falling on an outstretched hand. The scaphoid bone, which is the first one here in the carpal row, as it's impacted from that fall, it can fracture that bone. And then the lunate can also be dislocated towards the palm. And I've got an image here in a second so you can visualize it, but it pushes if you look at your hand, it pushes the lunate forward towards the palm. And this can be a problem for some people, because the scaphoid, depending on where it breaks, scaphoid is a bone that is susceptible to a condition called avascular necrosis, where the bone dies. So because of how blood perfuses through the bone, a fracture in certain spots of the scaphoid, sometimes they don't heal. And if a person has a fracture like this, usually surgeons will monitor that fracture over a period of time to make sure that the bone fuses back together and heals. If it doesn't, sometimes they'll have to go in and put a pin in the bone just to make sure it heals and that it doesn't actually die. Okay, here's a fracture of the scaphoid right here. Okay, so one of the major bones of this radiocarpal joint. So you got scaphoid, lunate, and triquetrum. Scaphoid, lunate, triquetrum make up that, and pisiform, again, not part of the joint, but in this row as well. But there's that fracture through scaphoid. So they'd want to make sure, surgeons will check this and make sure it actually heals. If, I've had some patients before where it didn't, so they had to put a pin in here to help it fuse back together. And here's I mentioned lunate can dislocate as well. It's hard to see on here. I'd never be able to pick this up, but a radiologist can look at this, and here's the lunate from an anterior-posterior view. From a lateral view, the lunate can be pushed towards the palm and dislocated, so that's something that would have to be corrected if it happened. Okay, and then osteoarthritis of the thumb, one that you hear about fairly often. This again, I feel like the girls get the short end of the stick on a lot of these, but don't worry, I've got lots of disorders that mess with guys too, but in this lecture, a lot of females. So, also people like myself who use their hands a lot to work on people. I use my thumbs a lot to work on patients, so I have to be careful to make sure to give that joint a rest and not beat up on it too much, because you can develop osteoarthritis there. So it's typically bilateral, but again, if you have people who uses it in their profession and they do it just on one side, it can be unilateral with trauma and overuse. The CMC, that saddle joint, basically erodes, and the joint will lose stability and begin to sublux. So it will sort of shift around and move abnormally. So you actually can have joint replacements of this joint, like you'd have your knee or your hip replaced. They can do a replacement of the CMC joint. I don't see a lot of patients with hand issues because they go to hand specialists, so I've never actually seen anyone with this, but it is a joint that can be replaced. And again, so strength and function would be diminished if this happens. So, people obviously you want to, maybe in the beginning it's just conservative work, trying to build strength in the surrounding muscles, add stability to the joint, and if that isn't sufficient, then maybe a joint replacement. And here's just that joint so you can visualize it. So here's the trapezium, that carpal bone, and then the first metacarpal of the thumb. So that's the carpal metacarpal joint, CMC, right here. And basically that joint erodes and osteoarthritis develops there. And again, surgeons can replace that joint if it doesn't get better with therapy. Okay, that's it. That is the end of the lecture. I know I went a little quick, but I hope that gives you a good sense. I hope this last series has helped you understand the upper extremity better. Again, next week I'm going to be out of town, so I'll start lower extremity the week after, and hope you'll come back and listen to some more. All right, everybody. Talk to you later. Bye.